Now, the most interesting and also from an economic point most important future application of brain-computer interface will be in movement restoration in stroke, in chronic stroke. The reason why this is because we have a dramatic increase in stroke in all industrialized nations, which is partly due to increased rate of diabetes, depression, and overweight. And these factors altogether increase the likelihood of bleeding in the brain or clogging an artery in the brain or breaking an artery in the brain and then causing a destruction of brain substance. So I don't know the number in the US precisely, but as far as I know, it's about 1 million people a year suffer from stroke. From this 1 million, 1/3 recovers within a year fairly good. Most of them can even go back to work without any treatment. 1/3 of those patients do not recover. They cannot go back to work. Their paralysis, however, improves slowly. So over the years, they learn more and more with good physiotherapy, ergotherapy, psychological therapy. They get better over the years. And then there's a third group, which is completely paralyzed after a few months after stroke, and they never recover. So we are using now, working with this third group, where we know even after 10 years after stroke, their hand function is not working. Their hand is hanging down there like this, and they cannot move it voluntarily. Now the question is, what can a brain-computer interface do here? And so far the results are surprisingly, I would say, optimistic. First of all, even chronic pain patients, chronic stroke patients, learn within about 20 sessions of 1 hour each, with a little simple prosthetic device on their hand, to move this prosthetic device, opening, closing the hand, grabbing a glass, by just sinking. So they sink. The activity of the motor system, which is mainly the so-called myorhythm, which is a motor-related cortical rhythm from 12 to 15 hertz, which is only over the motor system. We record it, and they imagine the movement. And when they imagine the movement over the finger area, this myorhythm goes down. We take it, and then we translate this into a stimulation here, or we just translate it to a prosthetic device, which then opens the finger or the whole hand. So most patients can learn this. With a prosthetic device, they can use this for opening, closing the hand, grabbing, sink, which is already a great success. Now the but comes. There's always a but in science. Now the but is, when these patients stand up after training, after 20 sessions of training, and they go home without the prosthetic device and without the electrodes in the brain, nothing. The learned movement is not generalizing out of the laboratory, which we know in psychology since many, many years, that generalization has to be learned. We forgot that. That's one reason. So the reason why they can't do it at home is no generalization training outside the laboratory. Second, in stroke, what you have an interruption of your voluntary command coming from here and going to the hand or the leg. And the interruption is the stroke, is the bleeding. So you have a cut in your nerves which bring your attention to the hand. Now, when you look how big that interruption is, it's very variable. We have patients who are completely paralyzed, but still have a small little fiber going down to the hand, but it's not working. So why it's not working? Well, it's not working because it's what we call a still fiber. It's not activated. It was never used. 80% of our nervous system is not used in our whole life. Everything we have in here, 80% of them we can throw away. It's useless. You use only a small part of it. So these fibers are not used, so the patients cannot use it. With intensive training, you can activate it. So BCI training, in some patients can activate these still fibers, and then you don't need a lot of training. But this is a small group only. Now the other group has a complete interruption. So we hoped that with training, other brain areas take over, and then they may be used and form a new fiber pathway down the hand. And that doesn't seem to take place. It looks like in most patients that's not working very well. For these patients who have a complete interruption of their fiber tract, they have to have the prosthetic device and the brain device connected to it all the time. Or, as we have it now, they go home, take it home, they put it on for about an hour a day when they want to have a dinner with their spouse or the family, and they want to eat like normal people. And then they have it on for the rest of the day. They put it away because it's very difficult to use while you move and so forth and so forth. So the third option, which in the US is strongly pushed, because the US always loves the most expensive medical treatments. So they say, we want to implant the whole system. So they open up the head, they put the electrodes on the brain directly, they make an internal fiber going in the body to the brain, then they attach the fiber ends to the muscles, and they stimulate the muscles by the thoughts from the brain. That, of course, is the most elegant solution, but it's the most expensive solution, and it's the most dangerous solution, because it, of course, carries the danger of infection, it carries the danger of many different things, which all these internalized instruments. But it's of course a very nice solution of the problem. The internalized system in the US is now tested only, as far as I know, at Brown University in Providence, and they tested it on very few patients, but it didn't work very well. That was another problem. It worked very well on the cortical side, but to transform the movement then in a useful way that you can grab glasses, that didn't work so well. And I have no idea why. We collaborate with that group because it's the most productive group we have in the US. And I think we have to go to different electrodes, and we have to be less invasive, and so forth and so forth. So that invasive solution is still, in the air. But the non-invasive, of course, is not as elegant, but it works. So if the industry is interested in it, they could take over right now and try it.